break in transmission. We'll be starting now. If you can hear, please indicate on the chat box. Okay. Okay. Thank you.
Thank you.
So let's continue from where we stopped. We are talking about heart failure and how it's a growing global health problem worldwide.
Heart failure is a major growing health problem worldwide, and it affects about 64.3 million persons globally. It is a huge problem and a cause for worry. Epidemiology varies widely within and between countries. The International Congestive Heart Failure Study, the largest study in Africa, was reported in 2021 by Professor Kamilu Karaye. It was conducted among 16 countries, 5 African countries, including Nigeria, Sudan, and all. Hypertensive heart disease was the most common etiology in Nigeria, Uganda, Mozambique, and overall, while ischemic heart disease was the most common in South Africa and Sudan. So it is a huge problem. Okay, this is the map showing the 5 African countries where the International Congestive Heart Failure Study, the largest study in Africa, was done. Nigeria, 383 participants, in Sudan, 501, in Uganda, 151, and Mozambique, 90, and South Africa, 169. Okay, the etiologies of heart failure from the study revealed that hypertensive heart disease was the commonest. It was reported in 2021, while followed by ischemic heart disease. Other etiologies found in the study include idiopathic dilated cardiomyopathy, rheumatic heart disease, valvular non-rheumatic heart disease, HIV cardiomyopathy, alcohol-induced cardiomyopathies, endomyocardial fibrosis, PPCM post-chemotherapy, congenital heart disease, endocrine metabolic disorders, and unnamed etiology. The overall prevalence of heart failure in the adult population in developed countries follows an exponential pattern, rising with age, affects about 6 to 10% of people aged 65 years. Relative incidence of heart failure is lower in women than men. Risk of developing heart failure is approximately 1 in 5 for a 40-year-old. Rheumatic heart disease remains a major cause of heart failure in Africa and Asia, especially in the young. Hypertension, as said earlier, is an important cause of heart failure in African and African American populations. And Chagas disease is still a major cause of heart failure in South Africa. It is a global body, as about 1 to 2 adults are heart failure patients worldwide. Admission rate is at least once a year. It is a global body. Heart failure with reduced ejection fraction is the commonest phenotype worldwide, about 50 to 60% of cases, while heart failure with preserved ejection fraction is about 30 to 40. 74% of heart failure patients suffer from at least one comorbidity. The comorbidity may be diabetes, it may be COPD, chronic kidney disease. It is a progressive disease with annual mortality rate of up to 10% or more. And the main cause of death are sudden cardiac death. This is usually due to ventricular arrhythmias or organ dysfunction due to hypoperfusion. 30 to 40% of patients die within 1 year, and 60 to 70% die within 5 years, mainly from worsening heart failure or sudden cardiac events. Patients with NYHA class 4, those with dyspnea at rest, have a 30 to 70% annual mortality rate, while patients with NYHA class 2 have annual mortality rate of up to 5 to 10%. Functional status is an important predictor of patient outcome.
Okay, so we've heard about the global burden of heart failure and how it is worsening. So what exactly is this heart failure? Because we know in this environment, sometimes we can hear about different things. If you hear heart failure, does it mean that the heart has stopped working? Does it mean that there's no life for the person again?
Well, a lot of myths about heart failure. Some people will say, okay, because of the presentation, leg swelling, somebody has stepped on juju. Some people will say it's village people. That is why we are giving this topic in this webinar. The current American College of Cardiology Foundation and American Heart Association guideline defines heart failure as a complex clinical syndrome that results from structural or functional impairment of ventricular filling or ejection of blood. And this leads to cardinal clinical symptoms of dyspnea and fatigue and signs of heart failure, which are edema and pulmonary waves. According to European Society of Cardiology, heart failure is not a single pathological diagnosis, but a clinical syndrome consisting of signs and symptoms. The cardinal symptoms of heart failure include breathlessness, ankle swelling, and fatigue. And that may be accompanied by signs which are elevated jugular venous pressure, pulmonary crackles, and peripheral edema. It is due to a structural and or functional abnormality of the heart that results in an elevated intracardiac pressures and or inadequate cardiac output at rest and or during exercise. So it has a cardinal symptoms and signs. It's not a single entity. It is a chronic progressive neurohormonal syndrome perpetuating cardiac dysfunction, and this is characterized during stress and or at rest by dyspnea, pulmonary and systemic venous congestion, inadequate peripheral oxygen delivery, and shortened life expectancy. European Society of Cardiology also give a universal definition as a clinical syndrome with symptoms and or signs caused by structural and non-functional cardiac abnormality, corroborated by elevated natriuretic peptide levels and or objective evidence of pulmonary or systemic congestion. So we can look at this schema, the symptoms of heart failure, and corroborated by at least one of the following: elevated natriuretic peptide levels or objective evidence of cardiogenic pulmonary or systemic congestion.
Okay, how does the person get to develop this heart failure? What is the mechanism by which the body that was functioning normally ends up developing heart failure?
Heart failure occurs as an imbalance in three key neurohormonal systems in the body. The key neurohormonal systems are the renin-angiotensin-aldosterone system, the sympathetic nervous system, and the natriuretic peptide system. The renin-angiotensin-aldosterone system and the sympathetic nervous system are the adaptive mechanisms that tend to restore the normal cardiac output, and also the natriuretic peptide system also work together with it. The natriuretic peptide system has a protective function which counterbalance the detrimental effect of the renin-angiotensin-aldosterone system and the sympathetic nervous system. The sympathetic nervous system is one of the most common adaptation in the body when there is heart failure, when there is drop in cardiac output, which occur early in the course of heart failure. There is activation of the sympathetic nervous system with concomitant withdrawal of sympathetic tone. The activation of the sympathetic nervous system provides a short-term support and then become maladaptive over the long time. So what it does is to bring about maintenance of cardiac output by causing a whole lot of system, causing sodium and water retention, vasoconstriction to maintain cardiac output so that the body can be able to get enough blood to function. So in patients with advanced heart failure, the circulating level of norepinephrine at rest are 2 to 3 times found in normal person. So that's to tell you how the sympathetic activity is in advanced heart failure. So it comes about to make sure that the cardiac output of the patient is maintained when the heart is failing. Oh, it is a progressive cycle, and this is caused by injury to the cardiac muscle by either hypertension, myocardial infarction, or other cause. So the whole lot of process of the renin-angiotensin-aldosterone system, the sympathetic nervous system brings about ventricular remodeling, and this ventricular remodeling worsens cardiac dysfunction, both systolic, diastolic, or both. So talking about the pathogenesis of heart failure, it is a progressive disorder, and this is initiated after an idiot event that caused damage to the heart muscle, resulting in either loss of functioning cardiac myocytes and disruption of the ability of the myocardium to generate force. The idiot event may be MI, may be PE, may be hypertension, it may be gradual or insidious pressure or volume overload, and hereditary or genetic cardiomyopathy. So when we look at this diagram, we can see an index event. An index event, as I've said earlier, may be MI, it may be PE. So an index event caused an injury to the cardiac myocytes, resulting into loss of functioning cardiac myocytes, disruption in the ability of the myocardium to generate force, thereby reducing the pumping activity of the blood. So when this event occurs, there is reduction in cardiac output, and when there is reduction in cardiac output, there is the neurohormonal system are set into play, the renin-angiotensin-aldosterone system, the sympathetic nervous system, and the natriuretic peptide system. So the main action of this system is to restore the cardiac output. So by the time these systems are set in place, the cardiac output is maintained. So at that time, the patient remains asymptomatic, and the ejection fraction when checked at that time is likely to be normal. So as it progresses with continuous activation of these hormonal systems, so there is what we call ventricular remodeling. The ventricle becomes remodeled to take care of the increasing pressure and then get dilated at the long run. So as it progresses, the myocardium become seeking the ventricular remodeling. The worst thing for cardiac output result in a progressive activation of this. Is the sustained activation of this thing become maladaptive and then disrupting the myocardium. So at a point in time of the patient life, the patient becomes symptomatic. We can see from the diagram that the patient can be asymptomatic, then later become symptomatic. So this may take years. And then when we look at the diagram, the index events, the myocardium become big. So this is the remodeling. As the remodeling is occurring, okay, the cardiac output is reducing, and then this mechanism, this activation of the system try to restore back the cardiac output, and then when this become maladaptive, then the patient becomes symptomatic.
So, what are the causes of heart failure? As we earlier mentioned, some people can say maybe because of the leg swelling, because of their finding it difficult to breathe, maybe it is village people or things have gone wrong. So, what are the causes of this heart failure?
Well, the causes of heart failure are enormous, but from the study from the International Congestive Heart Study, hypertension was found to be the leading cause, and hypertension is the leading cause in Africa and African Americans, while the Western world is chemical disease. Though the trend is changing, but hypertension is still the leading cause. From the clinical practice, from unpublished data in Cardiocare Hospital, Abuja, in order of prevalence, hypertension is still the leading cause, followed by cardiomyopathy, coronary artery disease, valvular disease, while rheumatic heart disease also is a cause. So the cause of heart failure is enormous, but hypertension remains the number one. So this diagram shows the etiology. Etiology of the heart failure could be valvular disease. There could be affectation of the mitral valve, the aortic valve, the tricuspid valve, the pulmonary valve. Maybe pericardial disease in case of constrictive pericarditis, pericardial effusion, high output state in anemia, sepsis, toxicosis. In volume overload, renal failure, congenital disease is there. In case of myocardial disease, coronary artery disease there, cardiomyopathy. in endocardial disease, endocardial fibroelastosis. Arrhythmia is also a culprit. Tachyarrhythmia, atrial arrhythmia, ventricular arrhythmia, body arrhythmia, sinus node dysfunction. So the causes are actually enormous, and it is not village people like people used to think. So from the study, this is a bar chart from the study of the International Congestive Heart Study, the largest African study. We can see from the diagram that the hypertension is present in all. This green is the hypertension. You can see it's present, and Nigeria has the highest body.
So is there a system to classify heart failure? Is there a way we can say, okay, this is how we classify heart failure if a patient comes in with this symptoms of heart failure?
Classification of heart failure is key in the management of heart failure. Classification can be based on echo ejection fraction. Heart failure, we have heart failure with reduced ejection fraction when the ejection fraction is less than 40%. Heart failure with preserved ejection fraction when the ejection fraction is greater than 50%. Then it can be classified based on distance severity. This is New York Heart Association classification 1 to 4. And it can be classified based on American College of Cardiology and American Heart Association staging that we'll see in the next slide.
Okay, so there are different stages and functional classification as earlier mentioned. Using the American Cardiac College classification or AHA and the New York Heart Association functional classification, which are like some of the most widely used classification system for heart failure. For the American Heart Association stages of heart failure classification, we have stage A, where the patient or the person is at high risk of heart failure, but there is no structural heart disease or symptoms of heart failure. Then stage B, there is presence of structural heart disease, but the patient hasn't come down with signs and symptoms of heart failure. Stage C, there is structural heart disease with prior or current symptoms of heart failure. And then stage D, refractory heart failure requiring specialized intervention. This can mean the patient is on the maximum tolerable dose of some medication for over 6 weeks, but it's still not getting better. So there are some specialized intervention that should be done. Then for the New York Heart Association functional classification of heart failure, there is stage 1, which is no limitation of physical activity. That means the person can still go on doing their normal physical activity without feeling any or without having any symptom of heart failure. For class 2, there is slight limitation of physical activity. The person is comfortable at rest, but ordinary physical activity results in symptoms of heart failure. Maybe someone that lifts weights, someone that jogs, just a slight limitation of physical activity occurs in them. Then for stage 3, there is marked limitation of physical activity. The person is still comfortable at rest, but less than ordinary activity causes symptoms of heart failure. Maybe one like normal people or those without heart failure, maybe just climbing 2 to 3 flights of stairs. Normally, it shouldn't cause us to be breathless, but then they can feel breathless or get tired easily, or walking to the bathroom, they are getting tired. So there is a less than ordinary activity causing symptoms in them. And then in stage 4, they are unable to carry out any physical activity without symptoms of heart failure. That means they even at rest, when they are not doing anything, they are sitting, and they still have the symptoms of heart failure. And then we can see, we can try to compare the two of them because the New York Heart Association classification doesn't have stage A or yes, so there is none for them. But from stage B and C for the American Heart Association, it can correlate with either stage 1, 2, 3, or even stage 4, according to the New York Heart Association functional classification. And then for stage D, for the American Heart Association, can also correlate with stage 4 of the New York Heart Association functional classification of heart failure. So, how do we recognize and diagnose heart failure? If someone comes to your hospital or if someone comes to you in the clinic, how do you know that, okay, this person most likely has heart failure? How do you recognize the person and diagnose?
Heart failure can be recognized by the sign and symptoms. You know, if you remember the diagnosis, the definition, cardinal symptoms of sign and symptoms. Is, so the symptoms of heart failure include chest pain during exertion, shortness of breath, dizziness, swelling of legs, sudden weight gain, fatigue. So, other clinical manifestation includes dyspnea of varying degree, orthopnea. Well, this history can be gotten by asking patients the number of pillows they use. A paroxysmal nocturnal dyspnea. This is breathlessness occurring at rest and when patients about 1 to 3 hours after reclining to bed, making patients to wake up, sit up, and you know be breathless. So weakness, fatigue can be there, cough, reduced urinary output, tachycardia. They can have crepitations when we listen to the lung basis. They can have edema. They can have jaundice. They can have alternating weak and strong pulses, called pulsus alternans, and they can have cold, cool, cold, or pale extremities. On examination, when we look at the neck, they can have jugular venous distension. They can be cyanosis and third accent can be present. Other history to elicit in them include history suggestive of causes and history suggestive of acute decompensation. So history suggestive of causes includes cardiovascular risk. So that is very key because history taking is key in managing the patient to establish the risk factor. So cardiovascular risk factor, hypertension, diabetes, history of alcohol, history of COPD, structural pathologies, valvular stenosis or regurgitation, either history of congenital disease, ischemic disease, inflammatory condition like pericarditis, myocarditis, infiltrative condition like amyloidosis. So all history suggestive of decompensation, MI, acute infection, electrolyte imbalances, pulmonary embolism, arrhythmia, fluid overload, and all. So history taking is key.
So, as we've heard earlier on, history taking is key in diagnosing heart failure and like a clinical diagnosis. But then we do know that sometimes the picture cannot be clear cut, and sometimes to portray or to support what our diagnosis clinically, we do need to do some investigations. So, how do we investigate people or patients with heart failure?
Investigating heart failure, NT-proBNP is useful. It can help in diagnosis when unsure, and also can be used to follow up patients. Electrocardiography to check abnormality that could have caused, worsened, or complicated the heart failure. Though a completely normal ECG is possible but rare, ECG is mandatory on all patients with heart failure. Electrolyte urea and creatinine is also important. So this can help us to know whether there's complication of disease or treatment or coexisting renal dysfunction. Full blood count to know whether there is infection or anemia that may worsen heart failure. Chest X-ray is important to exclude pneumonia, food collection, and other diagnoses.
So, as you say, chest X-ray is important to exclude some diagnosis, but there are some key things, or there are some things you can see in the chest X-ray that can be suggestive of heart failure. And usually we use an ABCDE mnemonic to know things. A means alveolar edema or bathroom appearance. B is known as Kelly lines or interstitial edema. C is known as cardiomegaly, that's when the heart is enlarged. D is like diversion, upper lobe diversion of the vessels, then diversion of the vessels in the upper lobe, and then E is the pleural effusion.
Okay, from this diagram, we can see that this diagram of chest X-ray has all the ABC, D, E of X-ray features of heart failure. We can see the bat-wing appearance here. Okay, we can see the interstitial, the Kelly B lines, interstitial lines here. Is it? Okay. Then we can see the cardiomegaly, the cardiothoracic, we can see the cardiomegaly. Then we can see the upper lobe diversion here, upper lobe diversion. Then we can see, though not really clear, this is where the pillar effusion usually occurs. In further investigating heart failure, thyroid function test in all cases of heart failure is recommended. Why? Because to exclude hyperthyroidism as a cause, hypo or hyperthyroidism. Then lipid also to know about comorbidities, because if there is lipid abnormality, patient should be treated. Then glycemic profile, fasting blood sugar, random blood sugar, glycated hemoglobin. Alter ECG 24 to 48 hours depending to know the type of arrhythmia that may be precipitating the heart failure. Other tests include the D-dimer, troponins, COVID PCR, PT-INR, and etc. And investigating heart failure, echocardiography is very important, and is mandatory. The usefulness is invaluable. And when we ask for echocardiography, the following particular um, things should be looked at for. One, chamber size. We want to look at left ventricular internal diameter in diastole. We want to look at left ventricular mass index. We want to look at all the valves. Remember, we said that all the valvular issues can cause heart failure. We want to look at the mitral valve, the pulmonary valve, um, tricuspid valve. We want to look at the ejection fraction so that we'll be able to classify the patient whether into ejection fraction, heart failure with reduced, mildly reduced, or preserved. Then we look at E over E prime. E over E prime is a measure that can correlate with pulmonary capillary wedge pressure, typically greater than 5 in acute cases. The measure of left ventricular filling pressure, so it's elevated in acute heart failure. So those are the things we look at for. Also, we look at for wall motion abnormalities. So if you see wall motion abnormality, we're thinking of probably ischemic heart disease, then we do speckle tracking to know the global strain.
So there is a diagnostic criteria for heart failure, and usually this is based on clinical findings known as the Framingham's criteria for heart failure. It comprises of the major and the minor criteria. The major criteria includes acute pulmonary edema, cardiomegaly, hepatojugular reflex, neck vein distension, paroxysmal nocturnal dyspnea or autopnea, rales, third heart sound, gallop. Then for the minor criteria, we have things like ankle edema, dyspnea on exertion, hepatomegaly, nocturnal cough, pleural effusion, and tachycardia. That is greater than 120 beats per minute for the pulse rate. And then we now diagnose heart failure when there are two major criteria or one major criteria and two minor criteria. With this, we diagnose heart failure based on the Framingham's criteria.
This is the diagnostic algorithm for heart failure. So any suspected heart failure is, so we establish the risk factor, the symptom and signs, then maybe ECG, abnormal ECG. Then you go further and do NT-proBNP. So when the NT-proBNP is greater than 125 pg per mil or BNP greater than 35 pg per mil. If the answer is no at this level, heart failure is unlikely. So we consider our diagnosis. Okay, so if the answer is yes, heart failure is strongly suspected. So then go ahead and do echocardiography. After echocardiography, then abnormal findings. As we look at ejection fraction. So if ejection fraction is less than 40, you'll see this heart failure with reduced ejection fraction. 41 to 49%, heart failure with mildly reduced, and greater than 50%, heart failure with preserved ejection fraction. So then we commence treatment. This level. Okay, this is also what I've just explained earlier. Clinical history and physical examination. So we establish the clinical symptoms, the functional impairments, the pericardial disease, comorbidity, and drugs. Initial investigation. If all the initial investigation, ECG, chest X-ray, BMP, other labs are negative, so no heart failure. But if they are positive, so we assess ventricular function by echocardiography. Then if we find positive findings, then we can do additional diagnostic investigations. If assessment of left ventricular function by echocardiography is positive, heart failure is diagnosed. Also, if assessment of ventricular function is negative, we can consider additional diagnostic investigation. But if all these things are negative, then no heart failure.
So, when assessing heart failure as physicians, what are the things that must be contained in diagnosing this heart failure?
Heart failure is predominantly a clinical diagnosis, and a complete heart failure diagnosis must have five components. Must have five components. First component is heart failure syndrome, which is class EF classification if known. Then the etiology, the NYHA class and ACC class, precipitant, if acute presentation, and comorbidities. So this is an example for us here. Heart failure with reduced ejection fraction, that's number one, followed by secondary to hypertensive heart disease, that's the etiology number two. Number three is NYHA class 4, ACC stage 3. The precipitant is preceded by new onset atrial flutter and chest infection. Then number 5, the comorbidity could be diabetes, gastric arthritis, and all. So a complete heart failure diagnosis must have 5 components. 1, 2, 3, 4, 5. Heart failure syndrome with EF if known, the etiology, the NYHA class and ACC stage, precipitant, if acute presentation, comorbidities. So this is an example for us down here.
So, when we say case definition, we are talking about these three things: heart failure syndrome, based on the Framingham criteria, with or without laboratory findings, which is important is the brain natriuretic peptide or NT-BNP, and then with or without echocardiography, where we want to measure the ejection fraction, the E over E prime, the left atrial area index, and the LVID diameter. So that's the left ventricular intradiastolic diameter. So let us just take a case. This is a 52-year-old newly appointed minister. Noticed palpitations at rest and inability to complete his usual golf game and poor sleep, but attributes it to stress of the new office. His brother died last week in his sleep. Had never been told to have hypertension or diabetes. Had a checkup abroad 8 months ago and nothing significant found. On examination, he looks well, he's not breathless. Leg does not look swollen, but mild dimple after pressing for about 5 to 10 seconds after removing his tight shoes. The pulse is 102 per minute. It's regular. The blood pressure is 138 over 98 millimeter mercury. The JVP and the heart sound were not checked, and there was normal chest examination. So now these are the questions. One, what do you think? A, do you think that lifestyle modification is needed and review again in 2 weeks? Whether he has hypertension and need hypertensives, whether he has anxiety from new post brother's demise, and to give whether you like to give some anxiolytic and review again later after the burial. D, all of the above. And E, I don't know, Jerry. I need to evaluate further. So I want people to put on the chat box your comment, what people think. And then for the second poll, is it possible that he has heart failure? Yes, no, or I don't know. So let us comment on the chat box what our answers are while we discuss this case. So just comment what you think the answer is, whether it has heart failure, whether it should start treatment, or you don't know, and you need to evaluate further. Let me see some of the answers.
Chatbot is super.
Okay. I think the chat box is on, not disabled, but let's go back to the question. Okay. Can
Okay, let's look at the cells. I think somebody has replied.
Someone said one, the answer was C. Another person said all of the above, and two, yes, heart failure can be a diagnosis. Someone else also put option one, another person put B, the answer.
Thanks for the comments. So let's discuss. Okay, this is a 52-year-old newly appointed minister. Notice palpitation at rest and inability to complete his usual golf game and poor sleep. I want us to take it line by line. Notice palpitation at rest and inability to complete his usual golf game. So can this inability to complete his usual golf game be due to exertional dyspnea?
Let's go to the classification
Let's go to the classification.
of heart
Heart failure.
failure. So, based on this classification, if we're looking at the New York Heart Association, it said for class two, if you look at class two, it's slight limitation of physical activity, comfortable at rest, but ordinary physical activity results in symptoms of heart failure.
Let's go to the question.
So let's go to the question.
Okay. His brother died last week. Never been told to have hypertension or diabetes.
Even the first week,
Okay, the poor sleep here may be related to probably orthopnea or even PND. Just noticed and then poor sleep. So his brother died last week in his sleep. Never been told to have hypertension or diabetes. Had a checkup abroad 8 months ago and nothing significant found. On examination, looks well, not breathless. Leg does not look swollen, but mild dimple after pressing for 5-10 seconds. You know, most times when patients come to the hospital, they don't really know that they have leg swelling, but this is important. This patient has leg swelling. So can we go to Riframian's criteria? Okay. So this patient has minor criteria. Yeah, one. Then the distal exertion, probably, yes, distal exertion because of breathlessness on playing his golf. So for this patient, we have two minor criteria here. Can we go back to the, then also the poor sleep may be related to either of this, PND or topnia.
Okay.
However, in this patient, the 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 examination not detailed. Can we go back to the, okay? We can see that we say that we need examination is key, history physical examination. So for this patient, JVP and ASA not checked. So examination of the patient should be done.
So, based on what we discussed, um, one, you can see, yes, obviously, it doesn't have hypertension or does not need antihypertensives. Lifestyle modification needed and review again in 2 weeks. Uh, Not really. I don't think they then need to further review in 2 weeks when the review can be completed at the visit. He has anxiety from lupus and broad demise. Give some anxiolytics and review again later after the burial. No, we still need to probe further. We still need to evaluate further what the cause of some of these symptoms are. Sometimes they might link it to this their condition, the broad demise, the lupus, but not knowing that they actually have heart failure. And then all of the above, you know, I think we need to evaluate further. And yes, I think heart failure.
Yes, but we still need to evaluate further because it has two minor criteria.
Okay, we will have a member from the Cardiocare hospital that will be talking about bringing guests in, referring guests to the center. Starting now.
So thank you all for joining in, and thank you for staying with us. So briefly, I'll be talking about Cardiocare multi-specialty hospital. Cardiocare multi-specialty hospital is an arm of the Limi Hospital Group located at number 5 Giza Close here in Abuja. We are a healthcare institution that is considered a place for excellence in cardiovascular care. A support hospital and national referral center to hospitals, doctors, and training institutions. So basically, our focus is basically on safety, effectiveness, patient-centeredness, and international standards. That's what we do here at Cardiocare. And here are the list of the services that we offer here at the Cardiocare Multi-Specialty Hospital. We do cardiology, interventional cardiology, endocrinology, diabetology, and so many other advanced care treatment here. So basically, you can refer to us through, as you're watching on the screen. If you have patients that you need to refer to the Cardiocare multi-specialty hospital, this is the way you can do it. You can just write a sorry. So basically, you can just send in a referral letter from your hospital or from your facility to us, and you give a standard referral letter, and preferably you attach any available results so that we can do what we know how to do best. So for you to get across to us, you can see the emails on your screen. You can send it to frontdesk@cardiocare.ng, or you can send the WhatsApp message to the number that is displayed on your screen. So thank you so much. We also have a WhatsApp group where we share um, where we share insights, we share the activities we have so that you can join in. So for you to join our WhatsApp group, there's a QR code that is displayed on your screen. You can also scan it to join the WhatsApp group. And we also have a heart failure support group. The program holds every first Saturday of each month. If you know any patient that needs to be in this group, you can reach out to us and you can connect with us also. So thank you for your time, and we'll continue now as I call on the doctors to continue from here. Thank you so much.
So we are back from the break. So let's continue now. So now, heart failure. Sometimes when people hear about heart failure, I've seen cases where they feel like a death sentence. There is nothing they can do about it, because their heart has failed. They are dying the next day. So, is there a way we can actually manage or treat people that come down with heart failure? So, yes, in this situation, there are ways we can treat those that come down with heart failure. And the first thing we should do is to counsel the patient and family continuously. So it's not something, not a one-time thing that we need to talk to the patient and then call it quits or say it's a day. No, we need to do it. It's a continuous process. We need to counsel them on the disease nature. We need to tell them what heart failure is about. They need to know that it is not like malaria that maybe in 3 days you cure it, they take some medications and then the symptoms go and they no longer have malaria. No, we need to make it clear to them that this is a chronic disease that is for life. So we need to tell them about the disease nature, how it comes about, the adherence to therapy and follow-up, that there is need for them to adhere to therapy because, as I said, it's not like malaria that you take drugs for 3 days and then that is all. No, you need to take drugs continuously and for life. I need to tell them the implications of not taking the medications and the need for them to adhere to therapy and for follow-up. Then they need specialist review. Heart failure is something that they will need that is multidisciplinary. First of all, they will need to be reviewed by a cardiologist that specializes in things like this. They also need support groups. It is important for them to have support groups, and as earlier mentioned, we have one here. So now, can you just?
Okay, we have a heart failure support group in this hospital. It's a free monthly complimentary group, program for heart failure guests. So we provide community psychological and mental support for them to let them know that we physicians, we are with them in the journey of their disease. They are not alone. So the meeting is first Saturday of every month. We discuss a lot of educational topics, including even CPR there. The program is facilitated by cardiologists, psychologists, heart failure nurse, family physician, dietitian, are all specialists. So it's open to anybody that has heart failure. So you can refer any guest that you know is heart failure to join the group.
Okay. So you also need to counsel them on diet and lifestyle modification, and then where necessary, need for procedures. So we need to teach patients the rationale for their medications. So we need to tell them, okay, this is why you are taking some certain medications. Because sometimes you find out that if you let them know the reason why they are taking some medication, there will be more adherence to their therapy. So if you tell them maybe this one is because of the fluid you have, the excess fluid in your lungs, and the fluid in your leg, if the fluid in your lung not allowing you to breathe well, this therapy is to help clear these fluids and make you breathe better. Tell them, okay, this one is also to help reduce chances of mortality and to reduce, or in some cases, reverse some of the remodeling that might have happened occurred in the heart. And then you need to tell them the time they should take some certain medications. You know, there are some different medications that might be taken twice daily, some once daily, some, especially in some cases of comorbid conditions, they can have some medication that might be taken at a particular time of the day, like maybe at night. And then they should also be aware of some adverse reactions that can occur with some medications so that they can really come to the hospital and maybe if they need to be reviewed, their medication need to be reviewed, it will be reviewed. If it's something that needs to be changed, it will be changed. Then they should limit their fluid intake to 2 liters per day. As we said, with heart failure, the pathophysiologic mechanism, there is retention of fluid and salt. So we need to even limit the amount of fluid that is coming in orally to reduce the congestions. To teach them to follow a low sodium diet. They should weigh themselves daily and should notify the healthcare provider if they have an increase in weight of 1 kg or more. So usually we expect that those with heart failure symptoms, we expect at least 0.5 to 1 kg weight reduction per day, then until they are symptom free. Then you should also be aware of the patient's psychological needs because sometimes it can be very challenging to tell them that they will have to live with this for the rest of their lives and they will have to be on multiple medications. So you need to counsel them, and as we earlier mentioned, this support group can be very helpful to them on how to cope with the illness and medications. And then they should be taught about the some alarm signs that they can experience. Maybe someone that was previously okay with maybe New York Heart Association of Class 1, that the patient didn't have any reduction in physical activity. Suddenly, started developing dyspnea even with mild exertion. That they converted to stage 3. So it is important for them to know that that is an alarm sign. And as you said, maybe they were okay before their weight was stable, and then suddenly they say having increased, their weight increased, they say having weight gain of like 1 kg or more. So it's an alarm sign. Then maybe normally they were okay, they could sleep flat without any pillow. But now they are using 3 or 4 pillows to sleep. That means there is now an accumulation of fluids in the lungs. So it's an alarm sign. So they need to be aware and you need to let them know so that they can easily come to the hospital when they develop any of these alarm signs. And same thing with concurrent drug use. Usually, it's advisable that whenever a patient has heart failure, during each clinic visit, they should come to the hospital with all their medications. Because sometimes you can see that maybe they've gone to this other place and gone to some other places and they are now placed on 2 different medications acting the same way with the same function. So they need to come with their medication so that we can find out if they are using some concurrent medications. So,
The other alarm signs that the patient should be aware of include chest pain. So when they notice chest pain, they should come to the hospital. Then when they notice any weakness or maybe unilateral weakness, they should come to the hospital. Then when they notice that maybe, because we normally tell them how to check, we advocate that they should have their own BP apparatus. When they notice that their BP is, is low, very low, they should come to the hospital. Or their pulse rate is becoming low or very high, they should come to the hospital. Or maybe peradventure they put their hand where their pulse is and then becomes irregular and it wasn't there before, they should come to the hospital. Maybe when they notice maybe their urine is reducing in the maybe less than when they notice reduction in their urine within 3 to 6 hours, they should come to the hospital. So those are alarm signs, and then they should not stay at home, they should come to the hospital.
So the second thing is to reduce preload or afterload. Reducing preload is important because it reduces the work that the heart is doing to pump blood. And usually we achieve this using diuretics. And as I said earlier on, we want at least 0.5 to 1 kg weight loss per day initially. And then when the patient is symptom free, we maintain at that rate. And what the diuretics we use furosemide 40 milligrams BD, or we can give intravenous furosemide 20 to 40 milligrams totally if the patient is on admission. Or we can now use torsemide 10 milligrams BD or intravenously 10 to 20 etally if the patient is on admission. And then in some cases, like in refractory edema, and if the patient has good BP and normal sodium, we can give metolazone 1.25 to 2.5 milligrams once daily. Then the third thing is to treat the neurohormonal abnormalities. As we earlier mentioned, that there are some different medications we can use for that. The ARB, like the valsartan, candesartan, the ACE inhibitor, and the ANI, the sacubitril valsartan. So, is there anything we should be aware of when using this medication?
Okay, ANI is actually preferred, but when we are commencing patients on it, we should ensure 36 to 48-hour washout if we are changing from ACI and 24 hours for ARB. And these two drugs should not be combined. And the reason for the washout is to reduce the incidence of angioedema.
So some other medications we use the mineralocorticoid receptor antagonist like spironolactone or eplerenone, 25 milligrams daily, and the beta blockers such as bisoprolol, carvedilol, or metoprolol succinate, and the sodium glucose cotransporter 2 inhibitor like empagliflozin and dapagliflozin. So some other medications we can use include accessorized hydralazine or ivabradine.
Okay, 4 pillars. It's good to know the 4 pillars of heart failure treatment. Angiotensin converting enzyme inhibitors, ARB or honey, beta blocker, mineralocorticoid antagonist, and SGLT2 inhibitor. So these are the 4 pillars of heart failure treatment. However, other medication can be added, furosemide, furosemide, digoxin, depending on the patient's symptoms. But these are the major 4 pillars.
Yes. So they are known as the GDMT.
Okay, so when we look at this graph, we can see the cumulative benefit of these 4 pillars of heart failure, and these are the guideline medical directed therapy. So you can see relative risk reduction in all-cause mortality of up to 73. You can see the benefits of the cumulative benefit of all as against using 1, 1, 1, 1. Okay. Some patients may not tolerate ACIs or ARV, so in such category of people, adrenaline and sulfonylurea may be considered in patients with systematic heart failure with ejection fraction who cannot tolerate this, or they have contraindication to it. So this is a class 2B indication, meaning that should be considered in patients with who cannot tolerate this. And the digoxin may be considered in patients with symptomatic heart failure with reduced ejection fraction in sinus rhythm despite being on ACIs or honey, beta blocker, or MRA. Reason is to reduce the risk of hospitalization, both all-cause and heart failure hospitalization. Class 2B recommendation, meaning that should be considered. Then treating etiology, we use the same drug, then we optimize their management. Ischemic disease, we consider beta blockers, then percutaneous coronary intervention. For valvular disease, surgery. So we tailor the treatment according to the etiology. Then if there is arrhythmia, we treat arrhythmia with either anti-arrhythmic drug or beta blocker. If there is infection, we treat infection. If there are food overload, we give diuretics. If there is electrolyte derangement, we manage this electrolytemia. Now control hypertension with this drug to control the hypertension. So for cholesterol level, we give statin. We said earlier that most of them do have comorbidities. So if there's hyperlipidemia, we give statins. If there's simple blood sugar, and the diagnosis of diabetes is made to continue, we give drugs for the diabetes. If they have uric acid, we give glucosurgeon agents. If they have proteinuria, we can give ARB or ACI, depending. And then for specialist consultation, probably for nephrologist review. Then we consider other optimizing other cardiovascular risk factors. Oh, we cancel on low salt diets, water moderation, weight optimization, smoking and aqueous cessation. Very good. We treat comorbidities, COPD, and their inhalers for CKD, for nephrology consultation, give drugs that is compatible, adjust their medication according to the CKD, and they manage their CKD and others. So it's good to assess patient for device therapy, and device therapy is considered when a patient has been on guideline-directed medical therapy for 6 weeks and above. So all guests with heart failure with ejection fraction less than 35 or to 40 with normal QRS duration should have ICD. Reason for this is because they can have ventricular arrhythmia, which can cause sudden death. So any guest that has been on guideline-directed medical therapy for up to 6 weeks, then without improvement and then with reduced ejection fraction should have ICD. Then for guests with wide QRS duration greater than 135 should have, or LBB should have CRT, because to synchronize the left ventricle so that there can be effective pumping activity of the heart. All guests that survive cardiac arrest or have high ventricular tachycardia burden, meaning that 10 to 30% in 24 hours, should have ICD. Okay, so when considering device therapy in heart failure, as we said earlier, management of patients with reduced ejection fraction, these are guideline-directed medical therapy. Okay, with left ventricular ejection fraction less than 35%, with QRS less than 30, so ICD is recommended. Recommended should be considered. Left ventricular ejection fraction greater than 35% or device therapy not indicated or inappropriate. If symptoms persist, we consider therapies with class 2 recommendation, meaning that may be considered. When a patient is in sinus rhythm, less ventricular ejection less than 35%, PRS greater than 30, CRTD, we consider CRTD. Okay, KRS with 130 to 149 class 2A recommendation, meaning that it should be may be considered. Class 1 is recommended. So this is just a broader schema for what I've just explained. Okay, device summary by the NYHA KRS. Okay, if the If the QRS is less than 120 milliseconds, okay, we consider, and there is NYHA class 1, 2, and 3, okay, we consider ICD, but NYHA class 4, we consider ICD and ICD and CRT not really clinically indicated. But when the QRS interval is greater than 150, so with or without LBB, all the stages of NYHA should have CRTD.
So we want to monitor for clinical progress, complications, and quality of life. And one of the ways we can do that is using the Minnesota Quality of Life Index to check. Then it's an index that consists of some things which you can really check online. We explain.
Okay, Minnesota, for monitoring for clinical progress, complication, and quality of life, we have a Minnesota Quality of Life Index. With, it has 21 parameters. Is to ask questions about heart failure condition, how heart failure condition has affected the patient in the past 4 months. So each question has 0 to 5. Why 0 is no, 1 to 2 very little and very much. So it has 21 parameters, ranging from causing swelling in the patient ankle, making walking around difficult, making them heatless, making them breathless, making them depressed, and making them to feel like they are a burden to the family. So this is the questionnaire with Minnesota Quality of Life questionnaire. Then 6-minute walk test also can be used to assess patient quality of life and to monitor progress.
So we can also do a patient's subjective view of health and life, and they can tell themselves that maybe the breathlessness has improved, the breathlessness has reduced, whether they can walk a certain distance better than how they used to before. So their subjective view of health and life. And then there are other clinical parameters, and these must also be checked during each clinical visit. We want to monitor the New York Heart Association classification, whether it has improved, whether it has gotten worse. We want to check the blood pressure, the pulse rate, the jugular venous pressure, and other things that you need to check. So this is psychosocial support, including the heart failure support groups, clinical psychologists, and heart failure nurse. So,
Okay. Okay. Heart failure support group is very key in the management of heart failure patients, because it helps in getting improve overall well-being of the guest. So here in Cardiocare, we have heart failure support group. It's a monthly meeting every first Saturday of every month. The next meeting will be Saturday next week by 11 a.m. So if you know anybody that you think can benefit any heart failure patients within or outside Abuja, in Cardiocare, anywhere, please refer them to for the heart failure support. It will help them. It's facilitated by consultant, cardiologist, family physician, dietitian, nurses, heart failure nurses will take different educational topics, teach them how to recognize the alarm symptoms, how to manage their symptoms well. They meet with other fellow guests. They network. Sense of well-being is there. So it's a good support group for the heart failure guests. If you know any, you can refer.
and it's also free, so
It's free.
you don't need to pay anything.
They don't need to pay, and they don't have to worry about payment.
So the multidisciplinary management, as I earlier said, so you need a heart failure nurse, someone that's conversant with patients that have heart failure, a psychologist or counselor, a social worker, a primary care physician, cardiologist, both the clinical and interventional cardiologist, a cardiac surgeon when needed, a cardiac device technologist if required, a pharmacist, dietitian, and a health information management officer that are needed. So now, we know that in a lot of cases, those with heart failure can be managed at an outpatient basis. They can be managed at home. It's not all cases that needs to be here in the hospital and admitted. But now, we want to know when should the person who has heart failure be admitted? When is it needed for them to be on admission on the ward?
Admission is needed in acute heart failure, and acute heart failure can occur de novo, or it can be an acute decompensation of chronic heart failure. Acute heart failure refers to a rapid or gradual onset of symptoms and or signs of heart failure, severe enough for patient to seek urgent medical attention, leading to an unplanned hospital admission or an emergency department visit. So the four major clinical presentation include acute decompensated heart failure. This is in patients with already in a chronic heart failure, acute pulmonary edema, isolated right ventricular failure, cardiogenesis. So all these warrants hospital admission. So in a patient with suspected acute heart failure, so patient history, sign and symptoms of heart failure should be established, history taking and examination. So we do all this: ECG, pulse oximeter to check the SpO2, echocardiography, we do chest X-ray to look for all those signs that we talked about, and then to check whether there's pneumonia or features of heart failure. We do lung ultrasound and other specific evaluation. So this is from a European Society of Cardiology. This is what is recommended. So after all this, then we do natriuretic peptide testing. So if BNP, brain natriuretic peptide, is less than 100 picogram per mil, anything from BNP less than 300, so heart failure is ruled out. Acute heart failure is ruled out. But when the BNP, anything for BNP is greater than 300, so heart failure is confirmed. So suspected acute heart failure, we said, can come in cardiogenic shock and or respiratory failure. So for that, so we do pharmacologic treatments, probably can place them on inotropes if they come in cardiogenic shock, BP less than 90/60. Then we can give ventilatory support and mechanical support as necessary. So then we look for identification of acute etiology. So what is causing this in these patients? Also, is it acute coronary syndrome? Is it hypertension, emergency? Is it arrhythmia, charm, PIT? So is it pulmonary embolism? Is it this? So immediate initiation of, if all these are present, immediate initiation of specific treatment tailored against this is needed. If all this is known, then further treatment is required.
So I think this is a bit small. I don't know whether you all can be able to see it. Um, this is talking about a patient with decompensation, when they have congestion or fluid overload, or they can present with hypoperfusion, or they might not have hypoperfusion. So in those that have hypoperfusion due to the congestion, loop diuretics is considered if needed, and consider inotropic support. Then, if the relief of the acute, the hypoperfusion and congestion, then you can now optimize medical therapy. If not, you have to consider vasopressors like norepinephrine, and this is a class 2B indication. If they still have persistent hypoperfusion or organ damage, we can do MCS, which is a class 2A, and or renal replacement therapy, or consider palliative care. But if they don't have hypoperfusion, then you can also do with loop diuretics. It can to help in congestion relief. If they don't have any relief of their congestion, I mean they are still breathless, you can increase the dosage of the diuretics and even consider combination of diuretics. If they are resistant to diuretic, or if they have end-stage renal failure, you need to do a renal replacement therapy, or then you can consider palliative care. But if they respond to an increase in dosage of diuretics or a combination of dosage, then you can now optimize menstrual therapy. So the management of acute heart failure should be in a propped up position, that means in a cardiac position, if needed, oxygen and mechanical and or mechanical ventilation. It is oxygen therapy is usually commenced in patients with acute heart failure and a saturation of less than 90% or PaO2 of less than 60 millimeter mercury to correct the hypoxemia. Then you give diuretics and you can give vasodilators, and they may be considered to relieve the symptoms of acute heart failure when the blood pressure, systolic blood pressure is greater than 110 millimeter mercury, which is a class 2B indication, that it may be considered. And then inotropic support should be reserved for patients with left ventricular systolic dysfunction, low cardiac output, and low systolic blood pressure, that is less than 90 millimeter mercury, which results in poor vital organ perfusion. So whenever you have a low blood pressure of less than 90, left ventricular dysfunction, low cardiac output, consider starting the patient on inotrope with a class 2B indication. So vasopressor like norepinephrine will be considered in patients with severe hypotension, and the aim is to increase perfusion to vital organs. So you are giving them these medications so that you can cause contractility to increase perfusion to the vital organs. And some studies support the use of norepinephrine as first choice of vasopressor compared to using either dopamine or epinephrine. And then you should give a thromboembolic prophylaxis. Usually, it's given, this patient on admission, so there's a high probability that they might not be able to move as they are meant to move. Or even after that, they are going to be laying down on bed for quite some time, so they need to be anticoagulated. Usually, heparin, like low molecular heparin, is recommended unless when contraindicated or when unnecessary, maybe because of existing treatment with oral anticoagulants. So you might not give heparin. So this is management of diuretic therapy in patients with acute heart failure. So if they are, we can use oral loop diuretics, 20 to 40 milligrams of IV furosemide. Then if needed, yes, you can give 1 to 2 times the oral dosage, or if not, you can just give the 20 to 40 milligrams. Then you have to monitor the urinary sodium, the urine output. After 2 to 6 hours, you can increase to 50 to 70 milliequivalent per liter. After 6 hours, you can increase to 100 to 150 milliliter per hour, greater than or equal to 100 milliliter, 150 ml per hour. Sorry. Then you can double the dose until maximum dosage. You can repeat similar dose of this IV furosemide every 12 hours. Just keep monitoring the spot urine sodium and output. Our aim is to have at least greater than or equal to 50 to 70 milliequivalent per liter at 2 to 6 hours, and greater than 100 to 150 mils per hour of urine output. So you should continue this medication until there is complete congestion of the lungs. You check serum creatinine and electrolyte at least every 24 hours, and then yes, if you don't combine, you can also combine diuretic therapies. So if you've achieved this, you just keep on until they are decongested. If you've not achieved greater than or equal to 100 to 150, then you can now consider combination of diuretic therapy. But in all this, we need to monitor the serum, creatinine, and electrolytes at least every 24 hours. So, treating heart failure alone is not adequate. You cannot just treat the patient, maybe the person coming with acute symptom, you treat the decongestion and tell the person to go back and maybe not come back again. An important part of managing a patient with heart failure is ensuring that they follow up. So, how do we follow up patients with heart failure?
Yeah, medical therapy is not the only thing that is needed in the management of heart failure. Patient follow up is necessary because despite the outcome with medical therapy, addiction rate following hospitalization is still high, and nearly half of all patients readmitted to hospital within 6 months of discharge. So the key to achieving enhanced outcome must begin with good transitional care at the point of at the high index hospitalization. So how this is done is through a facilitated discharge, through a comprehensive discharge planning. Then the patient and patient caregiver education, because some patients are too sick, some are not just in the mood to even listen because of their condition. Then appropriate use of visiting nurses if necessary, and the follow-up can be done through telephone, can be clinic-based, and also use of telemonitoring when appropriate, although this has not decreased hospitalization, but then it has helped in following up of patients. Okay, so how often do we follow up these patients after discharge, after the index of hospitalization? Every first, every first to 2 weeks for 3 months. After the index hospitalization, patient should be seen on outpatient at every 1 to 2 weeks for 3 to 6 months. Don't forget mention the alarm signs that were then when notice any of this, that does not mean that they should not come even before this time. That is why patient education is key. So for after the index hospitalization, 1 to 2 weeks for 6 months, then after stabilization that we are okay, they are symptoms free. So we can ask them to see us 3 to 6 months for 1 to 2 years. Then to continue. Then for advanced heart failure, this patient should be seen 1 to 3 months. However, for this advanced heart failure, some of them may need frequent visits and may even reverse to being seen within 1 to 3 weeks. Okay, so what are the components of this follow-up? Medical history, ask about how they are doing, the physical examination. Okay, we examine them in the clinic. We just don't say, okay, you have come, let me refill your drug. We still need to examine them. Put our stethoscope on their back, okay, and listen to examine them. Is that raised JBP? Then even, first of all, before then, the medical history, is that worsening breathlessness? Somebody that was charged on an NYHA class 1, now coming back with NYHA class 4. So we need to take history. Are they taking their medication as prescribed? Are they not getting over the cancer medication that can worsen their symptoms? Then we assess their clinical symptoms. Is that dyspnea? Is that fatigue? Functional clinical status. We need to assess them and stage them at that time. They assess their quality of life. Even in our clinic here, Cardiocare, we use our Minnesota questionnaire to assess their quality of life. And even this quality of life can be assessed even by getting patient view about life. Sir, ma, how are you now? Are you better compared to when you were on admission? So we do ECG, electrocardiogram also, then blood tests as necessary. Echocardiogram is recommended every 6 to 12 months. Then other education and counseling on medication management, lifestyle, monitoring of warning signs, and advanced care planning. Okay, so we'll talk about remote monitoring also. Then the collaboration with multidisciplinary teams. We do this in the heart failure support group by cardiologists, primary care physicians, nurses. Then patient engagement and empowerment. We teach them how to take charge of their health, how to be involved in the management of their disease. When to take their medicine, when to check their weight, when to check their pulse, when to come to the hospital when necessary. We give care support and education. Then for patients with advanced heart failure, we discuss end of life discussion and even hospice care with them. Then management of comorbidity, diabetes, hypertension. Then vaccination, um, yearly influenza vaccination and this meningococcal vaccination, yes, every 5 years. Then with the use of the Minnesota questionnaire, we get a lot of them ticking, saying that they are depressed and they are depressed. So we assess depression and anxiety with the use of questionnaire also. We screen for sleep apnea and then we counsel them on their nutrition. So all this we do in the heart failure support group. So if you know any guest with heart failure, refer to Cardiocare. So for, as I've said earlier, for advanced heart failure, some of them may ideally should be some of them may require more frequent visits, although it should be 1 to 3 months, but some of them require every 1 to 3 weeks because of their status. So when they come, we do close monitoring of their weight, blood pressure, kidney function, and then we consider device. We assess them if there is need for device, either ICD or RT, or some of them may need surgical option, refractory heart failure, advanced heart failure. We cancel them of options of heart transplants and vesicular assist device. And some refractory that's end stage. So talk about palliative care. So in conclusion, heart failure is a major health challenge. Hypertensive heart disease is the leading cause, even from the study from the International Congestive Heart Failure Study, the largest African study, and from the non-published data from Cardiocare, hypertensive heart disease is the leading cause. The accurate diagnosis to history, physical examination, electrolyte, ECG, TT, and biomarkers is key. Guideline directed medical therapy and device therapy when needed is also key in their management. Follow-up of patients, follow-up clinic, regular clinics, follow-up, patient education, and support can improve overall outcome of patients with heart failure.
So we've come to the end of this session. We'll be taking questions. If anyone has any question, we'll be taking questions shortly. If you have any question, you can type it on the chat box. Okay. See some of the answers from the question we took earlier on. There are some questions here, taking them shortly. So you can ask your questions. They will start taking the questions shortly.
Okay, let's start.
Okay, one question here from Fatima. The person asked, thanks for the beautiful lecture, but How can we differentiate between right-sided and left-sided heart failure from history and examination?
Okay, thank you, Dr. Fatima Adebisi. Um, Congestive heart failure encompasses both right-sided heart failure and left-sided heart failure. But right-sided heart failure can be differentiated from left-sided heart failure by right-sided heart failure, we give leg swelling. In right-sided heart failure, they can have elevated JVP, they can have loud P2. So from history of right-sided heart failure, you can get history of maybe previous pulmonary embolism, history of pulmonary embolism. You can get history of COPD from history. But on examination, most patients with right-sided heart failure, they have pedal swelling, they can have elevated JVP, they can have loud P2. But in left-sided heart failure, they will not have leg swelling. Leg swelling is not there. Then they may not, leg swelling is not there. That's one of the most important thing in left-sided heart failure. In left-sided heart failure, they don't have leg swelling, but in right-sided heart failure, they have leg swelling, they have elevated JPP, they can have loud P2.
And the autopnea.
Okay, autopnea, PND, features of left-sided heart failure. Yes.
I hope we've been able to answer the question, Dr. Fatima Adebisi. So the next question, the person asked, how low is blood pressure too low in heart failure patients? So I think what the person is trying to ask is that what will we consider a low blood pressure for patients with heart failure?
Okay, the target BP range for heart failure patients should be between 90 to 130 over 60 to 85. So when the BP is less than 90, 60, it's too low for heart failure patients.
Okay. So as we heard, 90 over 60, anything less than 90 over 60 is too low for patients with heart failure, and they need to be evaluated, come to the hospital, and maybe for medication optimization. So can we get the recording and slide after the session?
Yes.
Yes, you can. Someone asks, what's the rationale behind seeing advanced heart failure patients every 2 to 3 months?
Okay, as I've said earlier, they are to be seen 1 to 3 months, 1 to 3 monthly. Well, this is for them to come to terms with the advanced heart failure. However, some of them may require frequent clinic visits because of the deterioration. It's advanced heart failure. They are being on up to the maximum tolerable dose of guideline directed medical therapy. So such patient, there is nothing really you can just do, but we discuss with them need for maybe surgical intervention like heart transplants and all. But why we see them is to breach the 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 heart failure and the heart transplant. So we call this bridge to transplantation. So the reason for seeing them, that is it. So to optimize, if we can see whether we can optimize their medication within that time very well, then to give them some time. However, some of them will still require frequent clinic visits, as I said earlier, like 1 to 3 weekly.
The next person asks, thank you for your lecture. Do you insert ICD in your hospital?
Yes, we do.
Yes, we insert ICD.
ICD, CRT, all interventional cardiologists. So what is not done here is not done abroad.
Yes. So someone asked, how can heart failure be prevented in hypertensive patients? Can obesity alone cause heart failure?
Obesity alone may not really cause heart failure. However, obesity, there is something we call obesity can actually be a comorbidity in heart failure. It can be a form of comorbidity in heart failure patients. However, obesity can cause right-sided heart failure because they have obstructive sleep. They can have obstructive sleep apnea and then right-sided heart failure, but it's not really the major cause of heart failure. It can occur as a comorbidity.
Okay, I think that to also add, yes, heart failure can be prevented in hypertensive patients. Taking medications regularly, ensuring that your blood pressure is optimal, and then coming for regular clinic visits as at when you can help prevent heart failure in those that are hypertensive. So yes, it can be prevented by what I just said. Okay. So
Okay, last question.
so someone asked a question. Thank you for your presentation.
Yeah. I appreciate your feedback.
Okay,
Okay, you should.
continue.
Mhm.
Okay, someone said, thanks for the presentation. The four and failure regimen mentioned, at what stage of heart failure would you introduce each of them?
Okay, yes, it can be introduced at any stage, but not, when they present with acute decompensation, you need to make them stable. So by the time they are stable and the BP can tolerate this, so it can be initiated at any time. But in acute heart failure, you need to take care of the congestion and then get them to a stable state.
Okay. The next question.
Especially in heart failure with reduced ejection fraction.
Okay, maybe I should also take some of the this thing.
Okay.
So thank you very much. Please, can you shed more light on how to prescribe SGLT2, especially for non-DM and ANI? Okay, SGLT2 inhibitor, example are the empagliflozin and dapagliflozin, and usually you can prescribe at 10 milligrams. But usually, even in non-DM patients, yes, you can prescribe the SGLT2 inhibitor. One thing we need to worry about is that in some cases, because of the kidney function, you just need to monitor the EGFR sometime before starting on this. And then for ANI, usually we just don't prescribe it. I think it's important to do an echocardiogram first to look for the ejection fraction before you can start ANI. So yes, you need to have an echo first. Then are patients supposed to be on diuretics even after stabilization? How about empowering patients to adjust their diuretic dosages at home?
Yes, patients supposed to be on diuretics even after stabilization, depending on, yes, after stabilization. Echocardiography is key, especially patients with reduced ejection fraction. Even if it's low dose, they supposed to be on diuretics, even if it's low dose with reduced ejection fraction. Yes, empowering them patients to adjust their diuretic dosage at home. Yes, we do that, but we tell them that whenever they notice that they are gaining weight, they should present the hospital. So this empowering them to adjust their medication should not be more than 2 days, because they may not really adjust it appropriately. However, it's good for them to learn how to do that. But when they notice increased weight gain, they are gaining more than 1 kg in a day, they should come to the hospital.
So the third question from the same person, are beta blocker dosages supposed to be increased progressively?
Yes, good question. Beta blocker dosage, yes, can be increased because in heart failure, the target, we want their BP to be between 55, yes, we can take 55 to 80. But when you are still getting 100 beats per minute at maximum dose of beta blocker, we are getting over 100 pulse rate, and then maybe the patient is on 5 milligrams, so you can increase it. Even there is room for ivabradine when you have not, when the patient is on, let's say, target optimal dose of beta blocker, let's say bisoprolol of 10 milligrams daily, and patient is still having tachycardia, so there is room to still add some other agent, which is ivabradine. Yes, beta blocker can be increased.
Okay, thank you very much. This was a wonderful time spent with you all. We've come to the end of the presentation. And as you said, Cardiocare is a multi-specialty hospital. All these mentioned are done here. The devices, implantation, the whole thing. As the consultant said, what is not done here is not done abroad. So everything can be done here. So thank you all very much.
Thank you all.
Okay.
See you next month.
Yeah, all right.